Hi, my name is Jorge Plutsky. I am the Director of Preventive Cardiology at the Brigham and Women's Hospital, and it's a pleasure to be speaking to you about diabetes and in particular its relationship with cardiovascular disease, some of the new progress in that area. That's a longstanding interest of ours. My conflict disclosures are shown here. It includes interacting with various companies that make medicines related to the treatment of diabetes and how they relate to cardiovascular disease. I thought perhaps we would begin with a question to put this into context. Which of the following statements are true regarding cardiovascular risk reduction in patients with diabetes? A, although glucose-lowering medications reduce microvascular disease, these agents have not shown decreases in macrovascular events like MI and stroke. B, GLP-1 agonists have been all found to reduce cardiovascular events. C, SGLT2 inhibitors decrease cardiovascular events with effects primarily on mortality. D, although PPAR gamma agonists are potent insulin sensitizers, they've not decreased the primary cardiovascular endpoint in a clinical cardiovascular trial. And as you think about that, let's go through these. What's interesting about the answer A is that was the correct answer for literally decades because efforts had been made for many years to try and decrease cardiovascular events by treating diabetes. Those had all not been successful in macrovascular disease, but showed a consistent benefit in terms of microvascular disease like neuropathy and retinopathy. But that's changed now, and certainly it's a new era upon us over the last several years, as we'll review. GLP-1 agonists have been shown to reduce cardiovascular events, but it's not been true for all of those GLP-1 agonists, so that's a subtlety in this answer, so it would be incorrect because they have not all been found to do that. So questions about class-wide benefit persist. SGLT2 inhibitors have been shown to decrease cardiovascular events, and the primary effects were on mortality, as we'll discuss, so C is correct. And D, PPAR gamma agonists are potent insulin sensitizers, and they had been shown to decrease the secondary cardiovascular endpoint in the past with pioglitazone, but now in the IRIS trial, that's changed. We do have a positive primary endpoint in a cardiovascular trial. So let's go through that. And the first one is just to establish the risk related to diabetes and cardiovascular disease. And there's many ways to demonstrate this roughly 2 to 4-fold increase in risk in patients who have diabetes. Here's data from the ERIC studies that just show across A1C levels increasing risk for diabetes or heart disease. It's interesting to note that this is a line one would draw for where we think someone has diabetes, and ERIC, as other studies have shown, reveal a relationship between risk even at lower A1C levels and future diabetes and cardiovascular disease. And so as one thinks about atherosclerosis in the setting of diabetes, the question arises is how is this process different? And one of the first things, of course, we've thought about for a long time is it must be related to high glucose because that's how we define diabetes. And there is still a fundamental question about whether atherosclerosis is distinct in people with diabetes or just the same disease augmented. And one of the things that is important to recognize, certainly colors the clinical course of patients with diabetes, is that it's a very complex disorder as laid out here in this perspective that we had offered, that yes, glucose is important, and we know a lot about new pathways like advanced glycation end products, of which A1C itself is an example of that. But there are many other inputs into why someone with diabetes develops atherosclerosis, classic risk factors like hypertension and LDL levels, but diabetes often involves high levels of insulin. There's insulin resistance present in skeletal muscles that contributes to the picture. We know that fat tissue is very important and active in terms of releasing mediators that contribute to postprandial lipemia, inflammatory signals, high free fatty acid levels. There's a distinct dyslipidemia with high triglycerides and low HDL. There is a shift in coagulopathy with various mediators coming out of the liver that shift towards increased coagulation, and then some of those inflammatory mediators are primarily from the liver, like CRP. So one note I think will be a subject of continuing attention is demonstrated in the DECODE study, where they looked at future risk for cardiovascular events and mortality, not using A1C, but using rather responses to an oral glucose tolerance test, which may be more sensitive. And what you see here is subsequent mortality over the 10 years of the study based upon those who had normal glucose tolerance. Here you see people with diagnosed diabetes. It's interesting that it's no different than those who had undiagnosed diabetes, and you could look at that and say, well, here's an example where prior therapies have not been changing things. You'd like to think once the diagnosis is made, we have interventions that change the course. But one of these areas of the future is the fact that people with impaired glucose tolerance, shown here in the lavender, who've not yet developed diabetes, still have a shift up in terms of their risk based upon oral glucose tolerance testing. And I think that becomes important now that we have evidence for benefit about how cardiologists may be involved with identifying diabetes, and of course a big push to have cardiologists start treating diabetes. This is just another study that demonstrated this increased risk for cardiovascular disease in people with earlier forms of that, impaired fasting glucose or impaired glucose tolerance, in this meta-analysis with a large number of patients. We do have evidence that highlights why cardiologists would be paying attention to this issue. Here are 3 different studies that followed up on a prior paper by Norhammer and colleagues that identified a significant prevalence of undiagnosed diabetes in people having a myocardial infarction. Similar data seen from Japan suggesting it is a global issue. In patients having a stroke and having coronary bypass, there's significant numbers with undiagnosed diabetes, and it can worsen outcomes. So I think finding diabetes may become part of how a cardiologist can be involved in intervening. We have spent time thinking about why those prior studies had failed before we get to the new data. And one notion is simply that A1C is not a very good predictor for future cardiovascular events, that there's a strong relationship with microvascular disease, but A1C isn't very predictive of future MI. So maybe it just doesn't work as a biomarker for cardiovascular risk. Interesting issue. And in terms of that question about identifying diabetes, I think one of the important points to note is that you can certainly check an A1C in your patients and find undiagnosed diabetes. But when you look at those patterns, it's worthwhile noting, as is highlighted in this recent study, that an A1C in this group would have identified 22% of patients. If one did an oral glucose tolerance, you would have identified 29%. If you just did a fasting plasma glucose and found it elevated, that's perhaps increased sensitivity for making the diagnosis. And when you combine these, you can do even better. So checking an A1C along with a fasting plasma glucose gets you to 90%. And the oral glucose tolerance test may be even more sensitive, but it's perhaps highlights tools to use about finding diabetes in your patients if you're a cardiologist. There's been a lot of interest in trying to target these various pathways that contribute to atherosclerosis, and one of the fundamental notions has been that perhaps we need broader interventions that hit more of these targets. And maybe this relates to why it's been challenging to show a benefit on just treating glucose and decreasing cardiovascular risk. This slide simply summarizes this experience I've referenced in the prior era of many studies in North America as well as the rest of the world, all pursuing glucose control to improve cardiovascular events. And when you bring those together, studies dating back to 1970, you see how it lines up on the identity curve, really no impact on changing outcomes. And one of those other explanations about why things had failed previously had been that we just didn't have the right drugs, that sulfonylureas and other medications previously used weren't the right agents. And it's noteworthy, as Silvio Nzuki has laid out nicely in this slide, that the number of agents available to treat diabetes exploded after 2000. We've had steady increase in drugs like antihypertensives, but not with diabetes agents. We have these new agents, so maybe that's one of the opportunities to improve outcomes. And given new safety hurdles that the FDA put in place for new diabetes medicines, we ended up with a whole slate of trials and these new agents trying to demonstrate safety and also consider benefit. And so here's a schematic from Dr. Nzuki about these various trials, with 3 of those family of agents being DPP-4 inhibitors, GLP-1 receptor agonists, and SGLT2 inhibitors, and the various trials that have been underway. Initially, this FDA safety hurdle, there were discussions that maybe it was unnecessary. We had a group of studies come back with the DPP-4 inhibitors establishing their safety, no increase in events, but no benefit. There were insights gained from this that could be relevant, with signals around perhaps increased heart failure with some of the DPP-4 inhibitors, and that remains relevant as we admit patients and see patients with heart failure. If they're on a DPP-4 inhibitor, you may want to move away from that. But the real change came with the first trials that actually showed demonstrated benefit, which occurred with a GLP-1 receptor agonist, liraglutide, and then also an SGLT2 inhibitor, empagliflozin. And I want to just break that down a little bit and first talk about GLP-1 and then about SGLT2. So GLP-1 falls into a family of signaling proteins known as incretins. And the first observations about incretins came decades ago, which demonstrated in a very elegant fashion that when one gives glucose by vein or by mouth and achieve the same glucose levels in the plasma, one always has an increased effect on the insulin response if that glucose came in through the mouth as opposed to by the vein, and established that there was a signal from the gut to our glucose homeostasis in terms of insulin response. And this study ultimately was one of the steps that led to the identification of the incretin family that involves this intestine secretion of insulin, where the name comes from, these gut factors, and GLP-1 is one of them. So this general pathway it arises from the gut. GLP-1 is released. It's a signal that goes to the brain that signals satiety, but it has systemic effects much more broadly. It's stimulated by food. We know the pathway is modulated in the setting of diabetes. DPP-4 is an enzyme that breaks down GLP-1, which is very short-lived in the plasma, and so the therapeutic use of DPP-4 inhibitors involves inhibiting that breakdown of GLP-1. And directly replicating the effects of GLP-1 is to give a GLP-1 receptor agonist, which doesn't break down as quickly and can directly activate GLP-1 receptors. And here's the top line, before we dig a little bit deeper into these studies, of the 2 studies that have now come out with 2 different GLP-1 receptor agonists showing a benefit on the primary cardiovascular endpoint to CV death, non-fatal MI, non-fatal stroke. And that was the LEADER study with liraglutide that showed not only was it safe and non-inferior to usual treatment, but it was actually superior. And then the follow-up study with a different GLP-1 agonist, semaglutide, also showed benefit. Again, safe, but actually fewer events in the SUSTAIN-6 trial. So here's the liraglutide, some 9,000 plus patients. They had established cardiovascular disease or kidney disease, as shown, and it was that primary composite endpoint. And here's the data that's presented in the New England Journal. The primary cardiovascular endpoint a significant reduction, 13% overall reduction. And when you look at the composite endpoints, they in general are going in the right direction, not much of a difference in terms of stroke. But supportive of the fact that there was a decrease in events and a lot of interest related to this, and a general sense that this seemed to be having an effect on atherosclerosis and myocardial infarction events as we started thinking about this in a little bit more detail. Now, we always like to see a second study, and even better if it's a different agent to support the idea of the concept. Here's the data from semaglutide, and the primary endpoint for semaglutide also showing benefit, and was quite supportive of this concept, but there is complexity here. Here's the data from another GLP-1 receptor agonist, lixisenatide, that again established safety, but did not show benefit. And so plenty of discussions about why there might be a difference among these agents, although I don't think that is clearly understood as of yet. There was thinking about perhaps the duration of action, long-acting versus short-acting. Certainly always discussions about trials and where they're done and the nature of those trials, but still not completely clear, I don't think. Nor is the exact mechanism for why these are beneficial. There are GLP-1 receptors in the heart as well as in the vasculature, creating the possibility for direct effects that might account for this, especially given the fact that prior studies looking at glucose control in and of itself did not show benefit. And there's also the possibility of indirect effects that are thought about in terms of neurohormonal axis, natriuresis, diuresis, glucagon changes that have all been raised but not yet understood. It is true clinically that both of these agents, the GLP-1 receptor agonists, will decrease blood pressure modestly and do have an effect on weight. Liraglutide actually available for as a obesity drug at a higher dose, and it is noteworthy, as we'll touch upon, that both GLP-1 receptor agonists and SGLT2 inhibitors both lead to some modest weight loss. And this is just showing sort of accumulation of some of the registration studies for liraglutide in various different settings compared to standard medications, the effect on blood pressure. And it's modest but consistently seen, and could this be part of a contribution to benefit? Here's a look at semaglutide that does lower A1C, of course, but also has an effect on weight. And there are additional studies ongoing about the implications of semaglutide and its effects on weight and its potential use for benefit. We do know that obesity, adiposity is a contributor mechanistically to lots of pathways that might be part of the story, whether it's inflammation, hypertension, some of the signaling molecules that have been implicated directly in atherosclerosis, some of the same pathways we talked about coming out of the liver that would suggest that perhaps weight loss may be of benefit. And some of those studies looking at GLP-1 receptor agonists in obese patients looking for cardiovascular benefit will be of particular interest given modulation of these pathways. One of those studies is semaglutide, the SELECT study that I happen to be involved with in terms of steering committee. Liraglutide is available at a higher dose, as mentioned, Saxenda, for weight loss. And again, returning to this concept that maybe benefit needs to happen by targeting multiple pathways, and there's certainly evidence for GLP-1 receptor agonists impacting many of these contributors. So here's a patient that I think would be very common for us as cardiologists to see in clinic. A patient with diabetes and hypertension has had prior stentings in 2014 and then again in 2016, has heart failure with preserved ejection fraction, is on an excellent regimen, LDL 60, so he's on a statin, his A1C is 7.4. And the question is, what other treatments could we offer this patient to improve outcomes? And I think this is a striking way to think about some of the advances, because what if we could offer this patient a 40% reduction in mortality? I think that would get our attention as cardiologists. So Let's think about SGLT2 in this question. Which of the following statements are true? SGLT2 inhibitors are involved in the reabsorption of glucose in the gut. SGLT2 is involved in reabsorption of glucose in the gut. SGLT2 provides a satiety signal to the brain, maybe part of its weight loss effects. SGLT2 inhibition decreases volume status, which could contribute to decreases in recurrent heart failure admission. SGLT2 inhibition is not associated with increased infection. SGLT2 inhibition does not cause hypoglycemia. So, running through these, SGLT2 is involved in reabsorption of glucose in the kidney, not the gut. It does provide a satiety signal, so B would be correct. SGLT2 inhibition does decrease volume status because it acts as a diuretic. SGLT2 inhibition has been associated with increased genital urinary infections, mainly superficial skin infections, but there is a signal for this. It often does not influence the ability to use it, but it is something to know about. And SGLT2 inhibition in and of itself does not cause hypoglycemia. If you're adding it onto drugs that are lowering A1C, it's possible you could get a compounded effect. But here's the effect of empagliflozin in EMPA-REG, the first positive study that was seen, and you see here this striking impact on mortality, decreasing events. And this effect on cardiovascular death, which was 38% relative risk reduction, was also seen in total mortality with a 32% effect. We like to see those line up. SGLT2 inhibitors work by targeting SGLT2 that's in the proximal tubule, and glucose is reabsorbed there. You could say a patient with diabetes with high glucose does not need to reabsorb their glucose, and if you block this, you could decrease glucose levels through glucose excretion, and that's what these various SGLT2 inhibitors can do, lowering A1C, and of course acting as a diuretic, so lowering volume and having a modest effect on blood pressure. You are excreting an energy resource in the glucose, and so there is weight loss associated with these, although it plateaus. And here are the results of the two trials, sort of top line, the EMPA-REG primary classic cardiovascular endpoint, and then the follow-up, the CANVAS and CANVAS-R studies with canagliflozin, both showing benefit and significant reductions, not just safety, but actual superiority. So let's look at EMPA-REG briefly. So was investigating 2 doses of empagliflozin in patients with known cardiovascular disease. Here's the 3-point MACE showing the changes in those composite endpoints. And you can see here this idea that it was really mortality, cardiovascular death that was really driving the result, and less so in terms of stroke and MI. There was a significant decrease in heart failure, and this has become a topic of great interest, with there now being studies looking at the use of SGLT2 inhibitors to treat heart failure. A 35% decrease in hospitalization for heart failure, which could be quite clinically relevant to the use of these agents and their benefits. These drugs do lower blood pressure with a significant but modest effect on blood pressure, but could be contributing to the benefit, or could be a signal for the pathways being modulated that have broader effects, as has been raised, the possibility of neurohormonal effects. Just as we talked about with a GLP-1 agonist, there is a modest but significant decrease in weight with these agents, and maybe this is modulating pathways that are contributing. In terms of the discussion about mechanism benefit, there's been a lot of discussion about this. The separation in the curves is impressive. It happens quite early. And why this might be happening is, of course, under discussion. Here's the second study with CANA, also published in the New England Journal, showing overall benefit. One aspect of this that receives attention has been a signal seen with canagliflozin around amputations, with there being an imbalance in that, with more in the way of amputations among those getting cana versus usual care. The mechanism for this has not been well understood. There has been attention now directed towards empagliflozin about does it also do that, and was there some reason for why this was uncovered and focused on, but that it's true more broadly. Thus far, it's not clear that it extends across the board, although the mechanism for why that would just happen with cana is not clear. This is an area of ongoing interest and study, and does raise questions about class effects. As an update, we now have 2 drugs in each of these 2 classes that have shown benefit. Here's just a breakdown of those composite endpoints with a lot of thinking about why are they working and why does it not extend across the class? Are there differences among them? But you can see here that, as might be the case in large cardiovascular outcome trials done for enrolling different patients in different places, that you can't completely line up all the action in terms of the GLP-1 receptor agonists. We see the MACE that's positive, and the components generally go in the right direction. With the SGLT2 inhibitors, there was this notion that really driven by effect on death. CANVAS, there was a little bit more across the board, but in general, the thinking has been GLP-1 having a more receptor agonist, those receptor agonists having more effect on atherosclerosis, the SGLT2 inhibitors more on mortality, but really the key finding is that both have positive MACE endpoints. Now, there had been a lot of interest in thiazolidinediones, rosiglitazone, and pioglitazone as targets for PPAR gamma, something that we studied in the laboratory, as did many other groups, and we knew of direct effects in the vasculature that argued for an anti-inflammatory and anti-atherosclerotic effect. A lot of discussions about differences between pio and rosi, with concerns raised about rosi that do not seem to have been borne out in terms of increased myocardial infarctions. These agents do have issues with, among some patients, of fluid retention and increase in emissions for heart failure, although reversible, not an effect on the myocardium. With pioglitazone in the PROACTIVE study before, it was a very complicated issue in that the primary endpoint in this study include many elements, including peripheral arterial disease, which is a very difficult disease to modulate, whether it's with a statin or any oral therapy. The secondary endpoint was the more classic cardiovascular endpoint of mortality, MI, and stroke, and all those components did go in the right direction and was positive, but it was the secondary endpoint, but led to ongoing discussions about pioglitazone in terms of those outcomes. An interesting signal in pioglitazone was this effect on stroke, and there was a 47% decrease, although the numbers weren't large in the PROACTIVE trial in those who had had a prior heart attack, and was the basis for the IRIS study, which looked at people with a prior TIA or ischemic stroke who didn't have diabetes but were insulin resistant, studying PIO, and also looking at MI in terms of outcome. And this was a positive trial with an impact on stroke in patients who had a prior history of TIA or ischemic stroke, and was significant in an area where there had not been a lot of progress in terms of decreasing events. And keep in mind, these are not people with diabetes. And so pioglitazone really aligns quite well with other therapies that we use to treat and think have an effect on stroke. Some looked at more directly and some indirectly, but this 24% reduction in the IRIS trial is suggestive. And follow-up studies have also suggested impact on MI and really aligns with the prior preclinical data with pioglitazone. We are beginning to see, and as cardiologists will have to be increasingly deal with the fact that the cardiovascular benefits of these agents are working their way into guidelines. The Canadian guidelines were out in front, but we're now seeing the other guidelines catch up and sort of suggesting that among certain patients, one should be thinking about the use of drugs that have benefit, SGLT2 inhibitors and GLP-1 agonists. When this came out, we didn't yet have those other agents and their benefits, so we'll see this continue to be highlighted as has come up. I think this is increasingly relevant. There are a lot of people with diabetes, 10% roughly of the US population. Aren't enough endocrinologists out there, many more cardiologists. And in terms of why cardiologists have ignored these prior calls to action to treat, as shown here from 2000, there are a lot of reasons. People were concerned about there being untoward effects, it not being something that we manage, and a big driver was the fact there was no cardiovascular benefit, and we know that's not the case anymore. We do have trials showing benefit, so I think we can't keep looking the other way. And I also think that an important broad conceptual point that we also can't lose sight of as cardiologists when we see patients with diabetes was some of the early evidence that showed the most benefit in terms of improving outcomes was the STENO-2 trial that found in a small cohort followed for a significant amount of time a 20% absolute risk reduction by treating all these targets aggressively. As compared to conventional therapy, actually trying to manage these down by using multiple drugs to get to the right blood pressure, lowering the LDL, addressing A1C, that one could achieve benefit. And I think this still becomes a guiding principle that we can't ignore the opportunity in terms of improving outcomes about addressing the many contributors to cardiovascular risk in patients with diabetes. So just to summarize, there's unequivocal evidence for the increase in cardiovascular risk. We now have evidence for decreased cardiovascular events through glucose-lowering therapies. For PPAR gamma, it still has issues and side effects like weight gain and fluid retention, concerns about bone fracture in a small number of patients. But in patients having recurrent stroke or recurrent progressive cardiovascular disease, one might think about the use of pioglitazone. GLP-1 receptor agonists, liraglutide, semaglutide showing benefit. We'll continue to see more data come out in this area. SGLT2 inhibitors, impressive effect on mortality, primary MACE endpoint. Interestingly, they work in the kidney, but there's been follow-up studies showing efficacy even in patients with renal dysfunction, but of course there's thresholds about that, so that's a separate issue. And I think that all of this data to an increasing extent is pushing us as cardiologists to be engaged in diabetes and its management. And I think that evolves across a spectrum of opportunities. The first is just to diagnose diabetes in your patients who may have unknown diabetes, not hard to do, and then to work with our partners in internal medicine, primary care, as well as endocrinology to get those patients treated. But there's going to be an evolution to other stages of this. One of those is just partnering with those physicians to co-manage diabetes, given the fact that the benefits are related to cardiovascular events, what we are responsible for, and that we are seeing a trend that will likely continue of cardiologists who are willing to treat diabetes. And I think that needs to be supported with novel models of how to make that happen, including introducing diabetes management into clinical training. So I'll stop with that. I hope this proved helpful in terms of an update about the effects of diabetic medications on cardiovascular outcomes, as well as thinking about the disease a little bit more broadly.